Good afternoon, and thank you for joining us today. Before we begin, I'd like to note that the views expressed in written conference materials or publications and by speakers and moderators do not necessarily reflect the official policies of the Department of Health and Human Services, nor does the mention of trade names, commercial practices, or organizations imply endorsements by the U.S. government. Next slide, please. Next slide, please. My name is Mackenzie Simmons, and I have the privilege of serving as the project manager for SAMHSA's 988 Crisis Systems Response Training and Technical Assistance Center that is operated by Altarum. Now let's take a moment to ensure that everyone in the audience is ready and comfortable with the technical aspects of the webinar. I'll now turn this over to my colleague Kaylee to walk you through the webinar interface, including how to submit questions and other technical information.
Thank you, Mackenzie. As you will see, closed captioning is enabled for today's webinar, and you should be able to see that across the bottom of your screen. We also have American Sign Language capabilities, and you will see the interpreters are spotlighted throughout the presentations. If you need any technical support during today's webinar, please reach out using the Q&A function, and I will address it for you. Lastly, if you have any questions for presenters during the presentation, please enter them into the Q&A area, and we will address them as time allows after the presentations during office hours.
Thanks, Kaylee. Next slide, please. Today's webinar is the second session of 6 in a series of webinars called Connecting to Serve: Promising Practices for 988 and 911 Collaboration. The second session in this series is intended to assist organizations in working with existing 988 and 911 coordination teams or to build new partnerships within their states. The goal of this webinar is to discuss and explore the various key partnerships that come together to play pivotal roles within jurisdictions to deliver coordinated, comprehensive crisis care. After attending this webinar, attendees should be able to utilize promising practices to engage with collaborative 988 and 911 partners, such as local public safety answering points, or PSAPs, mental health providers, state mental health and substance abuse authorities, and emergency responders. They should also be able to conceptualize challenges and identify solutions around the implementation of 988 and 911 collaborative efforts, as well as identify resources available for establishing collaborative partnerships. Next slide, please. Before we start our presentation portion, I'd like to introduce Tiffany Russell. Tiffany serves as the Chief of Crisis and Justice Initiatives with SAMHSA's 988 and Behavioral Health Crisis Coordinating Office, is an advisor to the 988 Director and other members of SAMHSA's senior leadership in planning and determining policy, programs, and activities that address complex challenges in coordination of 988 crisis centers with law enforcement, 911 call centers, and emergency medical service providers. She also develops, recommends, and implements programs and provisions of guidance related to improving crisis response and equitable access to services for individuals with behavioral health needs that minimize unnecessary law enforcement involvement and promotes diversion from the justice system. At this time, I will hand things over to her for a brief welcome and to introduce our guest speakers.
Thank you, and welcome back, everyone. Thank you for attending the Connecting to Serve webinar series. We are thrilled with the feedback that we received from session 1 and are encouraged that this series is providing relevant and pertinent information for states, territories, tribes, cities, and counties that continue to actively work towards improved collaboration between 988 contact centers and 911 PSAPs. This is also a special shout out to Frederick, Maryland's 911 Center that shared with us that not only did they watch session 1, but also shared it with other 911 professionals. We hope that all of you find value in this series and will also share it with others in your communities and in your profession. Now, before I begin the introduction of our speakers, I want to acknowledge SAMHSA leadership that have supported and continue to support this portfolio of work. Thank you to the Assistant Secretary, Dr. Miriam Delphin-Rittman, and her executive leadership team, to the Director of the 988 and Behavioral Health Crisis Coordinating Office, Monica Johnson, Deputy Director, John Palmieri, Division Directors, Jill Mays and James Wright, and Senior Advisor, Dr. Richard McKeon, along with every member of the 988 team. I also want to thank our fellow colleagues from SAMHSA's Center for Mental Health Services, the National 911 Office, and Vibrant Emotional Health for their partnership in developing this series. As the federal lead organization of the 988 Suicide and Crisis Lifeline, as well as Behavioral Health Crisis Transformation, it is our mission to ensure that every person has someone to call, someone to respond, and a safe place for help when experiencing a behavioral health crisis. The office is working tirelessly to provide support, guidance, and technical assistance to states and jurisdictions, ensuring that people across the United States have access to the crisis care they need at their most vulnerable time. Today, I am so excited to introduce our panel of subject matter experts within the field joining us today, and we'll take a moment to introduce them now. Up first, we have April Heinze. She is the Director of 911 Operations for NENA, the 911 Association. She supports the NENA Development Group with operational standards and best practices. She educates, advises, and advocates for 911 and PSAP operational organizations issues on behalf of NENA with various industry associations and governmental organizations. Before joining NENA, April spent 24 years in a PSAP in Michigan. Our next presenter is Budge Career, currently serving as the Assistant Director of Public Safety Communications for the California Governor's Office of Emergency Services. He serves as the 911 State Coordinator, responsible for managing the statewide 911 system to over 450 public safety answering points with an annual call volume of over 27 million 911 calls. He also chairs the statewide 988 Technical Advisory Board, which has a focus on 988 and 911 coordination. Our next presenter is Karen Everett. She is the departmental specialist in the Crisis and Stabilization Services section at the Michigan Department of Health and Human Services. Karen oversees the contracted operations of the Michigan Crisis and Access Line, which serves as Michigan's statewide 988 center. She has significant experience in policy and legislation in the Health and Human Services field from her previous work in the department's Legislative Affairs Division and in the Michigan Legislature. Amanda Garrard is our next presenter and is currently the 988-911 Coordination Specialist for the Michigan Crisis and Access Line at Common Ground, where she is working to bridge the communication between 988 and 911 PSAPs in Michigan. Prior to her work at Common Ground, she dedicated over 18 years at a central dispatch center in mid-Michigan. She was a certified dispatcher for 13 years, and during her tenure, she served as the PSAP as a communications training officer, telecommunicator emergency response task force member, and a NENA member before being promoted to dispatch supervisor for the remainder of her career in the PSAP. Our final presenter is Julie Moss and serves as the Suicide Prevention Director for the Iowa Department of Health and Human Services, Division of Behavioral Health. Julie has worked at the Iowa HHS for 8 years and has 20 years of experience in the mental health field. She serves as the 988 Project Director and provides oversight to Iowa's 988 centers, leadership for integrating 988 into Iowa's crisis system, and co-leads with Iowa's 911 Program Manager the implementation of transfers from 911 to 988 in Iowa. As the 988 Director, Julie works across systems and departments to ensure coordination with 911 and implementation of 988, along with delivery of crisis services. And with that, I will pass over things to April to get us started.
Sorry, I was on mute. I apologize. Hello, everybody. I'm really happy to be here to share some of this information with you today. Next slide, please. So, how do you create a foundation of trust between 911 and 988? I think one of the most important things you can do to build that foundation of trust is to get to understand those that you are trying to build that trust with. One of the things that is really important to understand about 911 is that it is considered a local entity and it's under local control. And it doesn't really matter where you're at in the United States, it's like that. There are approximately 5,800 911 centers across the country. Some of them are primary PSAPs and some of them are secondary PSAPs. Primary PSAPs are the ones that are going to take the 911 call. Secondary PSAPs are those that are going to dispatch the 911 calls. There are a lot of similarities with all of those PSAPs, but no two PSAPs are exactly alike because, again, as a local entity, there are many different things that will take place at a local level that in one municipality they'll do and in another municipality they won't. So there's always differences between every single one of them. It's also important to understand that there's really no federal control over 911, nor really over public safety in general. There is very little, if any, state control over 911 in some areas. We have state 911 authorities in a handful of states across the country. And then we have home rule states that do things completely different. Typically, state 911 authorities will take in funding for the state. They will purchase the equipment, and they may have specific requirements of each of the 911 centers. But ultimately, again, 911 is a local entity, so the vast majority of control is at the local level. That means that really, when it comes to 911, the way 911 does things similarly is through standards. Standards give 911 a baseline for operations and technical requirements. Next slide, please. So in 2020, during the 988 state planning grants, Vibrant required state grantees to create 911 implementation plan, 988 implementation plans. One of the requirements of those plans was to build a coalition of stakeholders. And those stakeholders would be essential to 988 as a whole. Some of the stakeholders that they identified were individuals who live with lived experiences, representatives from one or more Lifeline Crisis Center, state suicide prevention coordinators, county or regional mobile crisis providers, providers of crisis respite stabilization services, law enforcement leaders, 911 and PSAP leaders, peer support providers, and other state and local mental health and suicide prevention advocacy groups, such as NAMI, MHA, and AFSP. Next slide, please. We have had some really amazing states that have created very strong partnerships between 988 and 911. We're going to actually hear from some of those states just in a few minutes as we move through the webinar. Those states really moved that needle by moving these coalitions that they had to create into working groups that really focused on a couple of different components of the grants. One was building the relationships between 988 and 911, and also related law enforcement response folks as well as the potential for 911 diversion to 988. Next slide. So how do you start this in your local area? We are going to hear from some of these states that have done this. So we're going to hear some of their best practices. But one of the ways that that you can move this forward at your state level, if you have not got one of these working groups today, is by working with your state's mental health and human services agency. Have them create a working group that focuses on issues of relationship building and that potential for warm transfers. The people within the state to help identify working group members within 911 would be reaching out to your state's 911 administration. So every state has a 911 administrator. There is a national organization. I'm sure Budge can speak more about this in his presentation, but the national organization is called National Association of State 911 Administrators, or NASNA. And they have an amazing resource to help identify who your state point of contact is when it comes to 911. And the website is right there, nasna911.org/contact-911. Other organizations that can assist you with getting 911 resources is your local chapters of NENA and APCO, which is the Association of Public Safety Communications Officials. These here are links on this slide that will take you directly to the location on their web pages to identify who the chapter leadership is and how you can contact them as well. Next slide, please. One important task that NENA does is NENA is a standards development organization. We create operational and technical standards and best practices for the 911 industry. Very early on, we began working with SAMHSA to identify needs for the 988 and 911 communities. We decided to create a standard, a 988 911 interaction standard. This standard has participants from a vast array from the 911 community, both the industry side as well as the municipal side. From Vibrant, SAMHSA, we have numerous behavioral health organizations. We have members from the FBI, the U.S. Department of Transportation, Department of Defense, emergency medical dispatching protocol providers, and countless others. We had, I think, at one point, about 190 participants within this standards development. Next slide, please. In the standard, these are some of the items that will be discussed. One is rules and expectations of the 988 and 911, legislation, funding, guidelines for referral, transfer, and sharing of information. Next slide, please. In addition, the standard covers operational analytics, training considerations, technical explanations between 988 and 911 because the systems are very different. Technical experts, apparently that's on there twice, I apologize. 911 staff training and wellness education and 911 and 988 staff. Next slide. There are also 4 different appendices. I'm going to highlight just a couple here. In Appendix A, there is going to be a sample memorandum of understanding between 988 and 911, and you can create, it will be the sample wording, and you can add to that based on local needs. There also is an agreement for information sharing, a baseline standard for standard operating procedures, and a decision tree matrix. Next slide, please. So the 988 and 911 interaction standard is currently in public review, actually just finished public review. We did receive several comments. So the standard working group is mitigating those comments right now. Hopefully those comments will be finished by, we're hoping, early January. It will have to then be sent out for a second public review. And then the standard hopefully will be published shortly after that. On the horizon, we do have a version 2 of the standard. That work will begin immediately upon the publication of version 1. And we highly request your input. You are, as subject matter experts in your area, your input is invaluable to the process with these standards. In the second version of the standard, we're going to go further into technical needs as well as additional needs of operational expectations. Next slide, please. And I think that is all. Nope. With this closing recommendations, carefully choose the stakeholders, and that how to do that is by getting input from your trusted sources. Plan early, identify gaps, assess existing gaps, learn about data and transferring capabilities, examine all 988 and 911 interoperability models, and establish a process for developing procedures and protocols. Next. And now I will turn it over to Budge.
All right, thank you, April. I appreciate that. So I'm going to go into some how we applied some of the things, concepts that April introduced in California. And I really want to recognize the partnership in California between the Department of DHCS and also Cal HHS. There's a number of, and our 12 Lifeline Crisis Centers in California. It's all of us working together that produces this body of information that you're going to see here. So if you can go to the next slide, please. I'll talk a little bit about the groups that we have existing in California first. So we have a 911 advisory board. The state has been managing 911 in California for many decades. And through that process, we've developed various committees. We have 58 counties in California. There's a county coordinator in each county. We've established regional planning groups. As you can imagine, we're quite a large state. And we've really focused on this interaction between the state and the 450 public safety answering points, or PSAPs, throughout the state. So with that backdrop, when this 988 conversation began, we started looking at what would it look like from a governance perspective to bring these communities together. And we eventually developed 2 different advisory boards through our California legislative process, and it's now in California statute. We have a technical advisory board that I chair, and then we have a 988 crisis policy advisory board. On the next few slides, I'm going to walk you through how we built these different advisory boards, the types of representatives that sit on those boards, and then I'll actually provide you some links where you can go deep dive on a whole bunch of additional information. So on the next slide, talk a little bit about just understanding and appreciate some of the unique differences between 911 and 988. And really, this is all in the context of understanding the goal of what are you trying to achieve as you begin these conversations. Early on, a couple of years ago, these communities, 911 and 988, had really not interacted very much. And so initially, there was just a lot of understanding. To give you a quick example, a typical 988 conversation via a contact might take, say, 10 or 15 minutes. A typical contact to a 911 center via a 911 call might take 100 seconds, or a little over a minute and a half. So you can see there's just a vast difference in how the centers function, what their goals are. You need to really get a good understanding of state, local, and federal requirements, meaning statutes, and also guidelines. As April said, each 911 center is different, and we've learned that of our 12 988 centers, they're all slightly different as well in how they function, how they're organized. While they all have the same mission, just the way that they do things is different. So this next bullet, really think about, go visit these centers, sit down and understand their workflow and how it is that they're serving those in the community that reach out for them when they're in need. And just appreciate that as you gain this understanding, new technologies come along, best practices really mature, and it's an evolving process, continually changing. So you've really got to focus on how do you improve that quality of care? How do you put a feedback loop in all these processes to make sure that you're having an ongoing conversation? And this is really the context that we had when we go to the next slide. We'll talk about what it is that we developed here. When we developed our technical advisory board, there was some statutory requirements. In other words, things identified in California law that we had to include as a baseline in the membership. We took that and expanded it to what we thought we would need to have a meaningful conversation to develop the recommendations that we would eventually put in place from a technology perspective. So as I said, I chair it. We've got representatives from our California Health and Human Services Department. We have county behavioral health folks. We have emergency medical folks that are involved in the conversation, 988 crisis centers, mobile crisis response, and then the two chapters that were mentioned in CalNINA and NAPCO. These are our APCO and NINA associations that exist within the state. And then we knew we needed representatives from 911 centers. And we also have a organization that oversees our peace officer standards and trainings in the state. And I want to make this really clear. When we formed this group, we weren't looking necessarily for leaders who were at the highest level in these organizations, although we have some of them. Really looking for practitioners who can contribute to the conversation on how are we going to put technology in place that really helps facilitate the interaction between 911 and 988. On the next slide, I'll talk a little bit more about the working groups that we formed and what we've done. So we really, our statute required us to focus on these three bullets: the feasibility for interoperability between 911 and 988 and the behavioral health crisis services that are out there, the technical and operational standards that allow for interaction with our 911 system, and then the standards and protocols that govern transfers between the two. And when we began this journey, we immediately formed 3 working groups. The best practices working group went out there to gather that body of information from others that are doing similar things, either at the state and local level. We have a group that's focusing on the interaction between 911 and 988. And then something very important for California, making sure that the technology is accessible and provides equal access to anyone who wants to come through this 988 program to get help. These working groups have deliverables and they have regular meeting schedules, and they report their progress back out to the larger 988 Technical Advisory Board. On the next slide, I talked a little bit about what we have on the technology side of this. Well, there's also a policy advisory group that we formed. This advisory group actually met for the first time yesterday. The meeting was from 10 to 3, so you can see it was a pretty long duration meeting. And these are the representatives that were there. There are over 32, I think they're up to 36 members of that board now, and really trying to get the community as a whole, all of the organizations, the agencies, the entities at the state and local level that are involved in developing policy around 988. And you know that this is a very large landscape, and this effort is being led by our California Health and Human Services Agency. On the next slide, we'll talk a little bit about how the members were selected. And this is really hats off to Dr. Antu Bui over at HHS and our Deputy Secretary, Stephanie Welch. They really led the effort on this and providing really the thought beyond how do they form a proper board. Want to make sure they have professional experience, community perspectives is important. Everybody needs to come with a collaborative mindset, with the ability to listen to, gain different perspectives, and then reach consensus. You can imagine with the size of our state, what might work in, say, LA County that is extremely, urban. We also have very, very rural counties where they're, just a few thousand people. A lot of diversity with respect to race, ethnicity, gender, sexuality, disability, geographic representation, all of that needed to be factored in. And then we wanted to make sure there was representation for people with lived experience. And it was with this mindset that they developed this board. If you go to the next slide, this is a short summary. If you go into the statute, there are 14 different requirements that this policy advisory board needs to make sure that they address. I'm not going to go into a lot of detail here, but there's a lot of information that's been made publicly available. So if you want to do a deep dive in what this board is focused on. On the next slide, there's if you go to the next slide, there's a graphic here that just kind of gives you a visual representation of the two different boards and the purposes that they serve. And really, the goal here is to achieve what you see at the bottom, statewide collaboration, keeping in mind the legislative requirements that are there. On the next slide, which is my final slide, these are links to current information on all of the meetings that we've had, all of the documentations we've produced. And I really encourage you to visit these links just to see what we're doing in California. You'll find everything from charters to agendas, live recordings of the meetings we've had, and any deliverable we've produced are all available on these links. I know it's a lot of information. I'm going to turn this over now to Karen and Amanda from Michigan as they go over what they've done in their state. Thank you very much.
Great. Thank you, Budge. All right. First of all, thank you everyone for joining today. I greatly appreciate the opportunity to present and the chance to talk about what we have going on here in Michigan. Next slide, please. I want to start by taking some time to quickly talk about how we have 988 set up in our state, just for some background and context as we move through this presentation. We currently have 4 988 call centers, 3 regional centers that are primary in their area, and 1 statewide center that covers the rest of the state for a total of 83 counties covered. These 3 regional centers were previously answering NSPL calls and opted to remain as 988 centers in their respective areas. The Michigan Crisis and Access Line, which is Michigan's statewide 988 center, serves as a primary center in 76 counties and also serves as backup to those other regional centers. Next slide, please. Just a little bit of background on the Michigan Crisis and Access Line. Our legislature did a lot of legwork in the creation of MyCal. It was developed out of the House CARES Task Force, which was comprised of state representatives, and the Michigan Psychiatric Inpatient Discussion, and was ultimately formalized into state statute in January of 2020. So this means that the creation of MyCal actually predates the transition to 988, and Michigan was able to get a head start in the creation of our model and our resources. The original intent or the idea that came from our legislature was for MyCal to serve as a one-stop shop for behavioral health resources, which ultimately laid the groundwork for these resources to be available to Michiganders calling 988. MyCal is staffed by Common Ground, and they have over 50 years of experience operating a crisis line. Our call specialists are hired from all over the state of Michigan, and these positions are remote positions. It was really important to us to ensure that these Michigan calls were being answered by people living in the state and familiar with the state of Michigan. We've also found that a remote workforce has been extremely beneficial. The entire line doesn't go down in the event of a natural disaster or a power outage or anything of that nature as it would with a physical call center. And it also allows them to hire staff from across the entire state instead of just in one area. We're also able to quickly staff up and bring people online in the event of a community tragedy or anything that may result in an increased number of calls. Next slide, please. For MyCal, Michigan built out a customer relationship management system. We call it our behavioral health CRM. Not only do we use this platform for receiving and documenting 988 calls, but we also built it out to host a number of other state administrative processes, including CCBHC certification, our community mental health service programs, or CMHSP certification, customer service inquiries, and more. It also houses a number of resources. So we are fully integrated with Michigan 211 and can search those resources directly within our own system. And we've also provided our PIHP for prepaid inpatient health plans and CMHSPs with access to the system through what we call the partner portal. From here, they update their crisis services and resources into what we call service cards, which MyCal can then search for in the system and provide as resources to individuals calling in. With that being said, MyCal activates, but it does not dispatch crisis services or mobile crisis. Using the crisis service information provided, for example, if that area has a crisis hub, hours of availability for the service, contact numbers to reach out directly, MyCal would then contact the local entity to dispatch that service. Next slide, please. Moving into our coordination between 988 and 911, Michigan created a 988 and 911 work group that meets monthly. And this group consists of all 4 Michigan 988 centers, our 988 and 911 coordination specialist, which we'll be hearing from soon, and our state 911 administrator, as well as several Michigan PSAPs. The overarching goal of this work group is to establish best practice recommendations for 911 and 988 coordination at a local level. Thus far, we've established the Michigan 988 Center protocols. We've created shareable informational documents that are publicly available. You can see an example on screen of one that we've created that shows when to call 988 versus when to call 911. We've also created another graphic that highlights 211, 911, and 988 in the state of Michigan. The first step in collaboration is learning. And this group has been beneficial in that it provides a forum for all of these differing perspectives and professions to openly communicate and inform each other. Right now in this work group, we are currently discussing gaps in information sharing between 911 and 988, common practices regarding emergency intervention, and drafting best practice language on diverting 911 calls to 988. And at this point, I would like to turn it over to Amanda.
Thanks, Karen. Go ahead and go to the next slide. So I'll just talk real quick about my position. The purpose of my role as the 988 911 coordination specialist is really to be the bridge between 988 and 911 here in Michigan. So the role requires that I'm involved in all things 911 and emergency intervention related at the MyCal 988 Center, as well as participation in the Michigan 911 988 work group. So my regular ongoing duties include coordinating with the directors of Michigan ECCs and PSAPs, coordinating with MyCal 988 Center staff and reviewing emergency interventions that the MyCal 988 Center crisis specialists had to engage with 911. So when I'm coordinating with the PSAPs, that includes information sharing about things like 988 updates and call reviews. It includes education, both for the PSAP about 988 call handling and emergency interventions, but also educating myself about each PSAP's unique processes. So though I have an in-depth experience in a 911 center, as you've heard already, each ECC and PSAP across the state and across the country are different. So knowing the wide range of differences allows us to get a better picture of best practices that will benefit everyone. So, and that is where coordinating with the PSAP continues and is headed, which is to coordinating MOUs and developing best practices together that everyone trusts. So my role as a coordinator within my own the MyCal 988 Center involves training our staff about 911 and continuing education about emergency interventions and our interactions with 911. I am also able to give input about our CRM that Karen mentioned and discuss if there's anything that is needed in the system that can help us better process our calls. So another piece of my ongoing duties is reviewing the emergency interventions and other medium to high risk calls that our crisis specialists get. And while reviewing, I'm looking to make sure that we're exploring all lesser invasive options first before contacting 911. And that coordination with the PSAP went smoothly if we did need to contact them. I'm also looking out for aspects of the call that show a trend that there's a need for training in any specific areas. Then next slide, please. So I wanted to go over some coordination successes that we've had. I have had meeting after meeting with PSAP directors. They're not really sure about 988 or what is to come. Even though we've had NSPL, we're really being intentional, collaborating with the 911. So at the end of the meetings, I'm seeing that they're breathing a little bit easier and even excited and looking forward to using 988 as a resource for their callers. So this may seem like a small success, but it's a huge step in the trust that's monumental for the foundation to move forward. One success specifically I wanted to highlight, we have had one PSAP that while they don't yet transfer to 988 as a official diversion process, they do utilize 988 to support callers in crisis while they're waiting for emergency services to arrive. So it happened once in a particularly busy shift that they knew they should stay on the line with this person, but they had a lot of other calls coming in. So they came up with the idea to transfer the caller to 988, tested it out. It went very smoothly. And since then, they've transferred many calls in a similar manner. So again, there's no policy just yet in their PSAP to do this, but it's an excellent example of a starting point for PSAPs that aren't sure. If they've already got emergency services on the way, but still need to keep this person on the line and they know it's going to be a while, transferring it to 988, our center has worked out well. And then one last success I want to highlight is the coordination with PSAPs, that it's really stirred the agencies to get their policies, SOPs, and call handler guides updated. During conversations, I'm finding that many agencies do not have mental health or suicide specific guides. So this coordination is highlighting the need for those in their agencies, and the PSAPs have really stepped up to create and or update their current procedures. Next slide, please. So some challenges that we've had and that I've had personally is that initial and continuing challenge is getting a response from the PSAP directors to meet. While I've met with many PSAPs, there's still many of the 120 PSAPs that I'm trying to coordinate with that have not responded directly to any communication attempts. And that's okay. The directors have many things on their plate. So setting aside time for something that they may not understand or see the importance of quite yet, it leaves me with some limited access for one-on-one meetings. So here in Michigan, we are working closely with the state 911 administration, and they have been our advocates and are pushing the PSAPs to make contact with me, set up those meetings to start collaborating more closely. Another challenge is just building trust. It's slow, and you'll hear trust. You've heard it already. You'll hear it again, I'm sure, is though we can explain our process of how it will be, we're just one 988 center in the nation. So not only are these PSAPs receiving calls from other 988 centers around the country that may not do it exactly how I describe, they're also receiving calls from completely different crisis lines. So that's been a challenge, trying to explain how the different crisis lines work to the directors when they have questions. So building trust when the process can seem inconsistent is difficult. And again, though NSPL has been around, this seems new, and new can often be challenging for some. 911 is constantly, they have to be thinking about liability. So it can be difficult for agencies to even consider letting go of a call, transferring it to 988 to de-escalate by lesser invasive means when they think about what could happen with this call. So it's extremely important to discuss options that address liability. And one last challenge that I wanted to highlight has been getting agencies to move forward in their process. Now, again, as I'm talking to agencies, some are getting excited about the prospect of transferring calls, but many responses have been they look forward to seeing what another agency is doing, or waiting for the NENA standards to come out, or best practices. So the PSAPs are a little hesitant to be on the front side of transferring calls, and they're wanting to know exactly what it looks like from all angles first. Next slide, please. So I want to lastly just emphasize the importance of trust. And the first year of 988, though NSPL wasn't anything new, we've spent the time we needed to build the infrastructure and get our processes together. And now our efforts come down to building that trust. So while coordinating, it is important to remember and express our shared goal. So at our center, we say helping people move from crisis to hope. And I know each 988 center and 911 centers alike are here to serve and help those in need. So another step to building that trust that I've witnessed over and over again in my meetings with PSAPs is explaining the process. So I've seen the fear of some unknowns subside and trust begin as the PSAPs get a better and full picture of what is happening on the 988 line. I explain aspects of our process from how the calls are routed, to the model that we use for crisis intervention, to what questions we ask, why we ask those questions, and explain the big difference between 988 and 911 call processing. When I started in this position, I went through CIT. So I was trained as if I was going to be on the lines, so I could thoroughly explain the work of a crisis specialist to those in the PSAP. So I do have an advantage because the PSAPs directors that I work with, they know that I understand the world, having come from 911 myself. So if you're anyone that is on the 988 side without knowledge of how 911 works, I suggest and really encourage you to dig in, get to know and understand the 911 process as well. I was able to make my 18 years of experience as a dispatcher and help our staff at MyCal know what's going on when they need to call a PSAP. So for both 988 and 911, it is crucial to understand one another's processes. So this clears up expectations, it calms frustrations, and enables us to keep working forward to our shared goal. So through it all, to keep building trust just comes from open communication about successes, challenges, and concerns, and even simple updated procedures just to keep that communication open. Next slide. So that, I thank you and I turn it over.
Thank you, Amanda. I am excited to be here today to talk to you about the work that we are doing in Iowa regarding some specific initiatives with 988 and 911. Next slide, please. Just to give you a brief overview of what 988 and 911 looks like in Iowa, as you've heard, in every state, it's different, and it gets more different as you go into the different PSAPs. So here in Iowa, we have the Iowa Department of Health and Human Services that provides oversight to our 988 centers. We have two 988 centers in the state, and they both provide 24/7 call, chat, and text for the entire state. On the 911 side, Iowa Department of Homeland Security and Emergency Management provides oversight for 911, and we have 110 PSAPs in the state. Next slide, please. I'm going to talk mostly today about our 911 transfer to 988 pilot project that we've started. We also are working on 988 warm handoffs to mobile response, which some of our mobile response teams are tied to 911. And then just briefly touch on a recent grant award that we got working on interoperability between 911 and 988. I do want to highlight on this slide that one of the things that Iowa HHS has been working on for some is building our relationship with our sheriff and deputy sheriff association. Iowa is a pretty rural state. We do have pockets of urban areas, but it is for the most part rural, and our sheriffs play a key role in responding to many mental health calls. So building that relationship has helped us to be successful in passing some pretty complex mental health legislation, and they have been a valued partner in that work. Next slide. So our 911 transfer to 988 pilot project, we started work on this probably about a year ago. And it really started because we had a few PSAPs that were ready to go. They wanted to use 988, they wanted to transfer, and they were starting to develop protocols related to transferring to 988. We decided at the state level, I met with our 911 program manager, that instead of having PSAPs leading the way, we wanted to lead the way from the state level and have a really coordinated and uniformed approach to how those transfers would look in the state of Iowa. So when we were selecting the PSAPs that would participate in our pilot project, we selected the ones that were interested. They said yes, they wanted to participate. But we also looked at counties that had law enforcement that had been involved in previous mental health initiatives, and also had a relationship with our 988 centers. So we pulled together a planning group. We met monthly. It was led by myself as the 988 project director, and then our 911 program manager. I want to point out that anything that we were doing that was related to 988 and 911, it was always co-led by the two of us. We also brought together leadership from our 988 centers and the 3 PSAPs participating. It was really important that we use the planning time to build and solidify relationships. I want to echo what Michigan said about building trust. It was so important during that planning period that we learn about each other and trust each other's expertise. Next slide, please. So some of the discussion points that we had during our planning period, first was how are we going to do this? What technology did we have that was available to us that would work for both our PSAPs and our 988 centers? So what we decided to do is that we would have a single phone line that is dedicated to the PSAPs participating in the pilot project. Another big conversation that we had was regarding our 988 center staffing and their capacity. We were concerned about their capacity to answer just our regular 988 contacts, but then also adding on an additional line. We went back and forth on if that line was going to be staffed 24/7 or if we were going to only have it staffed during the day or during peak times. And where we landed through those conversations is that it would be staffed 24/7. And the reason for that is because our PSAPs didn't want the added decision point or confusion for their dispatchers of looking through the criteria of what call to transfer, but then also having to figure out if it was the right time. So we landed on having our line staffed 24/7. Our 988 centers also worked very closely with each of our 3 PSAPs during the planning period on developing the criteria for transferring from 911 to 988. And then they also developed a training that they provided to each of the dispatching staff for the PSAPs. one of the things that we did at the state level is we developed a survey that we distributed to all of our PSAPs about their interest in collaborating with 988, what concerns they had, questions they had. We also asked if they were familiar with the mobile response in their area, or if their staff received training related to mental health, or if they would be interested in training. We tried to use that as an opportunity to get as much information as possible for how we can help them. We have 110 PSAPs, as I said, and we did get just over 30 responses to our survey. So it's something that we're going to continue to outreach to those who didn't respond and provide updates as the pilot project continues. Next slide, please. So here's our transfer flow that was developed by our centers and our PSAPs. One of the things that I think was so crucial in our conversations was the exclusionary criteria. There was initially some concern on the 911 side that the thought was that any call that had anything to do with mental health or suicide would automatically be transferred over to 988. And it was, I think it put their minds at ease when we're like, no, there are some calls that you need to be handling those. If someone is a threat to themselves, or if they are on a structure or a bridge, that is absolutely the time where you send out a response instead of transferring to 988. So having those conversations really built the trust and helped both sides to feel comfortable about this project. Next slide, please. Another thing that we are doing here in Iowa are 988 warm transfers to mobile response. Where that ties in with 911 is we have a few teams that use 911 as a dispatching entity. And we have one team in our most populous county who the only way to get the team is to be dispatched through 911. So we brought together all of our mobile response teams and our 988 centers. We organized it based on how they were dispatched, and we talked about what mobile response looks like in their area. It gave them an opportunity to ask our 988 centers about their staff, about their policies, and really get to know each other as providers and come to the understanding that we all want the same thing. We all want Iowans to get the help that they need when they need it. Next slide, please. So that just kind of gives you an idea of what mobile response looks like in Iowa. As I said, we have different models that throughout the state, and 911 does play a pretty large role in our mobile response system currently. Next slide, please. This is what our warm handoff process looks like. So even if mobile response looks a little different throughout the state, our warm handoff process from 988 is the same, where they're connecting the individual, if they consent, to the dispatching entity, and then the dispatching entity takes over. Next slide, please. So I'm going to touch just briefly on the Iowa project to improve interoperability between 911 and 988. We were recently awarded a Transformation Transfer Initiative, or TTI grant, that's funded through SAMHSA through NASHFID. We put in our application to really expand the work that we are doing related to 988 and 911 by having our 988 Tandem Call Pilot Project. The thought behind this is that, like I said before, we are a rural state and law enforcement is a primary access point to our behavioral health system. And how can we divert some of those contacts to 988? So the thought behind it is that if we have a first responder that's going out to a call and they see through their assessment that mental health is playing a role in the situation, that they're able to talk to them about 988, They're able to explain to them what the experience would be like contacting 988, and then provide support if the individual decides to contact 988. So they'll be there on site and help them feel comfortable during that contact, and then encourage them to continue to use 988 as a resource. Next slide. So as I said, this is very new. We haven't officially started work on it yet, and this just kind of lays out who we think the eligible applicants will be to participate in the pilot project. And then we do really expect them to pull input and feedback from their communities and gather that before we implement what the tandem calls would look like in their community. Next slide. And that is all that I have for 988, and I believe I'm tossing it back to Mackenzie.
So thank you to our speakers, April, Budge, Karen, Amanda, and Julie. We really appreciate you for taking the time to show your support for this series and share your expertise with the 988 and crisis systems community.